Hello, I am Dr. N.S. Mani, and in this third session of the cardiology for the postgraduate medical entrance test practice session, I will be discussing a few clinical conditions in cardiology which will be useful for you to build concept and also answer questions in the entrance test. Please visit the site www.youtube.com/acpgmed and subscribe. You can also have an account in facebook.com and invite this ACEPGmed, which address is given there, as friend, and you can get the links updated every day in your Facebook account as well. So please visit the channel, and you can see almost around 70 videos have been uploaded already. More than 12 question paper sessions with silent audio has been uploaded for you to practice, and more similar examination pattern questions will be transmitted in the coming days. Each of the video will be only less than 15 minutes, and it will from this session onwards, audio session also will be there. So we shall discuss the questions. The following associations are recognized. State which are true and false in the 5 options given. Down syndrome association with VSD, maternal tyrosinemia and congenital heart disease, Fragile X syndrome association with VSD, Noonan syndrome and cardiomyopathy association, and maternal phenylketonuria and congenital heart disease association. Please take a paper and mark the answers, freeze the video, and then after you complete the answering, go to the answer. Okay, that's the answer. The Down syndrome and VSD association is a true fact. Noonan syndrome and cardiomyopathy may be seen. Maternal phenylketonuria can also cause congenital heart disease in the baby. But the other 2 options, like maternal tyrosinemia and congenital heart disease, Fragile X syndrome and VSD, are not fully true, they are false. So we shall discuss. Down syndrome is associated with particularly AV canal defect like VSD and ASD. Fragile X syndrome is associated with mitral valve prolapse and aortic root dilatation. Noonan syndrome is associated with pulmonary stenosis or dysplastic pulmonary valve, ASD and cardiomyopathy. Maternal phenylketonuria is associated with VSD, ASD, PDA and coarctation of the aorta. So the embryology of atrioventricular valves is discussed now. So AV valves form during the 5th to 8th week of development. Initially, endocardial cushion tissue forms bulges at the atrioventricular junction. These bulges have the appearance of valves, and although such tissue may play an important role in the eventual formation of the atrioventricular valves, endocardial cushion tissues are not the precursors of the mitral and tricuspid valve. So diagrammatically representing the endocardial cushion, the sulcus tissue and invagination of the tissue on your left side panel down, and on your right side I am showing you the facies of a Down syndrome child. The facies descriptions can be found out in standard textbooks. Now continuing the embryology discussion, atrioventricular junction is guarded by 2 masses of endocardial cushion, superior and inferior cushion. These 2 masses would meet in the middle, thus dividing the common atrioventricular canal to right and left atrioventricular orifice. The process through which these 2 cushions fuse is not clear, and the role of apoptosis in this process is debatable. The fusion of the 2 endocardial cushions resulting in the formation of 2 atrioventricular orifices. In addition, the atrioventricular cushion appear to play a role in the closure of inter-atrial communication at the edge of the primum atrial septum. This septum grows towards the atrioventricular endocardial cushion and fuse with it. The ventricular septal defect can be very large if there is an AV canal defect extending beyond what endocardial cushion contributes to the ventricular septum. That is because the ventricular septum is formed from 3 structures. The embryology of ventricular septum we shall discuss in another situation. It is rare for a ventricular septal defect to be present with a small primum atrial defect, and even more rare without an atrial septal defect in an AV canal defect. The atrial septal defect is very variable in size in AV canal defect. Primum atrial septal defect is seen with a no VSD or a tiny inlet VSD. Cleft mitral valves are seen with primum atrial septal defect. A double inlet mitral valve is sometimes noted with primum atrial septal defect. Tricuspid valve may override the ventricular septum when cardia insert into the left ventricle, causing right atrial output to be directed into the left ventricle, which may lead to hypoplasia of the right ventricle. The left ventricular papillary muscles may be single or close to each other, causing mitral stenosis. AV canal defect is present in 50% of all children with Down syndrome and congenital heart disease. It is rare to have ventricular size discrepancy in children with AV canal and Down syndrome in comparison to other children with AV canal defect. Pathology of fallow or pulmonary stenosis could also be present in AV canal defect. Other types of congenital heart disease are common with the AV canal defect, except in those with the Down syndrome that tend to have either a straightforward AV canal defect or AV canal defect with a tetralogy of fallow or pulmonary stenosis. There are three types of AV canal defect: type A, B, and C. Type A is the anterior leaflet is divided and attached to the crest of the VSD. Type B means the anterior leaflet is divided and chordae from left side leaflet crosses and inserts in the right ventricle, which I have already described. And type C is anterior leaflet is ridging, single, with no chordal attachment, that is free floating. The atrial septal defect and ventricular septal defect will cause left to right shunting, leading to congestive cardiac failure. The right ventricular pressure will be systemic if the VSD is large enough. Patients with AV canal defect develop elevated pulmonary vascular resistance secondary to right ventricular hypertension, increased pulmonary blood flow, and upper airway obstruction in patients with Down syndrome. Children with Down syndrome tend to develop pulmonary vascular resistance elevation earlier, but not necessarily irreversible. On the right side, I am showing you the diagrammatic picturization and all the X-ray of AV canal defect, which shows cardiomegaly. Now, the another option was about tyrosinemia and its association with CHD. Tyrosinemia is an error of metabolism, usually inborn, in which the body cannot effectively break down the amino acid tyrosine. Symptoms include liver and kidney disturbance and mental retardation. Untreated tyrosinemia can be fatal. There are three types of tyrosinemia, each with the distinctive symptoms and caused by the deficiency of a different enzyme, type 1, 2, and 3. The type 1 tyrosinemia, also known as hepatorenal tyrosinemia, is the most severe form of tyrosinemia. It is caused by deficiency of the enzyme fumarate acetoacetate hydrolase. In the case of tyrosinemia type 1, it typically presents in infancy as failure to thrive and hepatomegaly. Primary effects are progressive liver and kidney dysfunction. The liver disease causes cirrhosis, conjugated hyperbilirubinemia, elevated alpha-fetoprotein, hypoglycemia, and coagulation abnormalities. This can lead to jaundice, ascites, and hemorrhage. There is also an increased risk of hepatocellular carcinoma. So you can say that it's one of the congenital metabolic disorders which can lead to malignancy. An infectious disease which can cause liver cancer is hepatitis B. So these two are important options you should remember. Then kidney dysfunction presents as Fanconi syndrome. Renal tubular acidosis, hypophosphatemia, and aminoaciduria are the three constituents of Fanconi syndrome. Then cardiomyopathy, neurology, and dermatologic manifestations are also possible in tyrosinemia type 1. So this is an important point to remember, because this explanation can be used in another question also. So I am showing you the picture on the right side, the left panel right side, tyrosinemia type 1, protein from food and protein from muscles, amino acids. And in the case of tyrosine, the FAH enzyme is absent, fumaric acid and acetic acid are not formed, and tyrosine level increases. It becomes succinyl acetone buildup and the health problems occur. The tyrosinemia 1 is due to enzyme. I already said the FAH deficiency is either missing or not working properly. And FAH is not working, it cannot break down tyrosine, which I already explained. Tyrosine and other harmful substances then build up, which as succinyl acetoacetate. And when it builds up in the blood, it causes serious liver and kidney damage. It may also cause episodes of weakness. And it's an autosomal recessive inheritance, where the both parents are carriers. And we can see down about the various patterns of inheritance from the carrier mother and carrier father, which already been taught in your undergraduate classes. Type 2 tyrosinemia, it affects the eye, skin and mental development. Symptoms often begin in early childhood and include excessive tearing, abnormal sensitivity to light, that is photophobia, eye pain and redness, and painful skin lesion on the palms and soles. About half of the individuals with type 2 tyrosinemia are also mentally challenged. In the case of tyrosinemia type 3, characteristic features of type 3 tyrosinemia include mild mental retardation, seizures, and periodic loss of balance and coordination. That is intermittent ataxia. Type 3 tyrosinemia is very, very rare. Fragile X syndrome was one of the options given in the question. Martin-Bell syndrome or Fragile X syndrome or Escalante syndrome, more commonly used in South American countries. These terms are used in South American countries. It's a genetic syndrome that is the most common single gene cause of autism and the most common inherited cause of intellectual disability. So that is another MCQ you can expect from this explanation. It results in a spectrum of intellectual disability ranging from mild to severe, as well as physical characteristics such as elongated face, large or protruding ears and larger testes, macroorganism. Then behavioral characteristics such as stereotypical movements, hand flapping and social anxiety. Fragile X syndrome is associated with the expansion of the CGG trinucleotide repeat affecting the Fragile X mental retardation 1 FMR1 gene on the X chromosome, resulting in a failure to express the Fragile X mental retardation protein FMRP, which is required for normal neural development. Another trinucleotide repeat is Huntington's chorea. Depending on the length of CGG repeat, an allele may be classified as normal, that is unaffected by the syndrome, a pre-mutation, that is there is a risk of Fragile X associated disorders, and full mutation, that is usually affected by the syndrome. A definitive diagnosis of Fragile X syndrome is made through genetic testing to determine the number of CGG repeats. Testing for pre-mutation carriers can be carried out to allow for genetic counseling. Aside from intellectual disability, prominent characteristics of syndrome include elongated face, which I already said, feet and orchidism. Recurrent otitis media, medullary infection, sinusitis are common. Speech may be affected, hand flapping can be there, social anxiety may be there. Males with the full mutation display virtually complete penetrance and will therefore almost always display syndrome, whereas females with the Fragile X syndrome may have symptoms ranging from mild to severe, although they are generally less affected than males. Here I am showing some of the pictures of the people face which look like, and also the Fragile X chromosome karyotyping, and also how the inheritance pattern occurs. Physical phenotypes are large or protruding ears, one or both, long face like vertical maxillary excess, high arch palate related to the above, hyperextensible finger joints, double joint thumb, flat feet, soft skin, post-pubescent macroorganism, that is larger testes in men after puberty, and hypotonia, there is a low muscle tone. Noonan syndrome is a relatively common autosomal dominant congenital disorder considered to be a type of dwarfism that affects both male and female equally, and is different from Turner syndrome. Congenital heart disease, typically pulmonary valve stenosis, ASD and HOCM, short stage learning disabilities, pectus excavatum can occur. It's an RASopathy, which means these are developmental syndromes caused by germline mutations in genes that alter the RAS subfamily and Mitogen-activated protein kinases that control signal transduction. So there are so many RASopathies. That is most common are, which you have to remember are Leopard syndrome, neurofibromatosis, and Noonan syndrome. So please visit the site spj.com.